With that being said, I would like to warmly welcome everyone to this very first session of our World Forum Capacity Training Series, which actually will consist of 5 different sessions. And based on the feedback shared by our members in the previous years, we have defined the key topics for each of the trainings. And we're very much delighted to welcome both our members as well as non-members today, and hope that the series will create opportunities to exchange knowledge, share practical tools, and strengthen networks, but also inspire new ideas across our global community. The series is designed to be a little bit more interactive than a traditional webinar, and also each session has a bit of a different structure. So today we'll be very honored to be joined by significant experts who will share their knowledge, research, and practical experience. We also see great value in the expertise present among all participants joining us today, and therefore, besides sharing your questions in the Q&A and your reflections and best practices in the chat, we also have reserved approximately 10 minutes for discussion after each presentation, in which we encourage you to participate in and engage with the speakers and other participants. So while we ask you to keep yourself muted throughout the presentations, we welcome you to unmute yourself during the discussion sessions if you would like to share a question or input or own reflections on the presentation given. Today the first session focuses on gender and trauma-sensitive prevention, an increasingly important area for organizations working in prevention, treatment, recovery. But before we officially begin today's training, it is my very pleasure to invite our international president, Amy Ronshausen, to officially open the series. Amy, please go ahead.
Thank you, Cressida, and I'm sorry if my face is really big in the screen, but I am trying to talk loudly because my computer's not working too well. Is it okay? Good enough, Cressida? All right. So for those of you who might not be as familiar with World Federation Against Drugs, we are a global network of civil society organizations committed to preventing drug use, promoting recovery, and strengthening balanced health-centered policies. Through collaboration with many of our partners who are joining us today across all different regions and sectors, we work to ensure that prevention, treatment, and recovery remain central to global and national responses. It is a pleasure to welcome you to our first session of the WFAD member training series on building resilience and inclusive responses to substance use and addiction. This series reflects something that we at WFAD have long emphasized, that effective drug demand reduction must evolve alongside our understanding of people, communities, and the complex factors that shape vulnerability and resilience. Today's session focuses on gender and trauma-sensitive prevention, an area that is both critically important and in many settings still underdeveloped. We know that substance use does not occur in a vacuum. Experiences of trauma, whether rooted in violence, instability, loss, or systematic inequities, can significantly increase vulnerability. At the same time, gender influences how individuals experience risk, access services, and respond to prevention efforts. If our strategies do not account for those realities, we risk overlooking the most in need and missing opportunities to intervene early and effectively. A trauma-informed approach does not simply ask, what is the problem? It asks what happened and how can we respond in a way that promotes healing, dignity, and long-term resilience. Similarly, a gender-sensitive prevention recognizes that a one-size-fits-all model is not sufficient. It calls for a tailored approach that reflects the lived experience of women and men, girls and boys, and the unique challenges they face. Importantly, integrating these approaches strengthens, not weakens, our prevention system. It allows us to build trust, improve engagement, and ultimately achieve more sustainable outcomes. At WFAD, we are committed to advancing a comprehensive, evidence-informed continuum of care, where prevention, treatment, and recovery are interconnected, and where no one is left behind. Today's discussion is an important step in that direction. I would like to thank all of our speakers for sharing their expertise and being with us today, and all of you for your continued commitment to this work. Your engagement is what transforms knowledge into action. I encourage you to actively participate, as Cressida mentioned, and ask questions and consider how the insights from today's session can be applied within your communities and your organizations. With that, I am very pleased to open this first session and hand it back over to Cressida to introduce our speakers. Thank you.
Thank you so much, Amy, for officially opening the series and also today's webinar. Without further ado, I'm very much honored to be joined by an outstanding panel of speakers with very strong experience from international, national, and community perspectives. And the first speakers I would like to introduce are Wadih Malouf and Karen Peters, who will share on the core foundations of prevention, understanding local realities, and the importance of trauma-sensitive prevention approaches. Wadih is the team lead and coordinator of the United Nations Office on Drugs and Crime program on drug prevention, and over the last decade his work has focused particularly on prevention among children, adolescents, and young people. And Karen Peters is a public health and policy specialist with over a decade of experience across the United Nations systems and global health sectors, and currently serves as a drug use prevention program officer with the UNODC. Please, Wadih and Karen, the floor is yours.
Thank you very much, Cressida, and also through you, big words of thanks also to Amy and everybody in WFAD for organizing this webinar and the audience, and I'm happy to share also this with other panelists. Can you see my slides, just to double check, or no?
Not yet.
Not yet? Okay, 1 second then. Let me do it the old-fashioned way. And yes, I mean, the main intent has been very nicely covered by Amy in her introduction remarks, but I think it's important as of context to describe a bit more. Can you see my slide now? Better? No?
Yes, but not yet the presenter mode. Yeah.
Mm-hmm. I usually get that window to switch modes.
Now we see your screen rather than the screen with the presentation. Yeah.
It's not even asking me to switch swap windows. It will come. I will stop sharing and I share again. 1 second. So when we say prevention, it's just important to contextualize that we're not, because we're talking about trauma, we're not, we're addressing prevention of the consequences that might be generated because of trauma. And it is in that context where my presentation that I hope it would work out now is going to be contextualized. So now it's working. 1 second. Allowing me to swap screen, that's all. Now it's working. Okay, perfect. Great. So yes, I do apologize, my computer was slow. So I will gain time to give more time to Karen. So yes, prevention and treatment, both of them, and Amy alluded to this, is a person-centered approach. The problem is the drug, right? But the responses that we need to undertake take into account the person and the context they are in. So whether it's prevention or treatment, the person-centered approach is important. And that gender lens is an important way to kind of contextualize how we're addressing the response. So it's not important to have only evidence-based and science-based responses, but to see who's getting these responses and do they have access to them, which is a core ingredient to ensure that no one is left behind. We do have UNODC guidelines in that effect, and this will be the red document that you have in the middle, where we tried as much as possible to kind of trickle down the science that exists, maybe for prevention responses or for treatment responses for drug use disorders on treatment and prevention of drug use. That's the lens we're coming in as UNODC. But there's not enough science that kind of analyzes gender differences in responses. We know the context is important, and I'll talk about the context later on, but the responses, very few of them analyzed their effectiveness between genders. And but the prevention standards alludes to that person-centered approach and talks about it, and I'll give you, but it's very important when we do a person-centered approach, doesn't only apply for drug use prevention. This applies for prevention of many other social outcomes. May it be the approaches wanted to end violence, may it be like the approach to end violence against children, the mental health of children and adolescents, all of them have to account for when a person's gender differences. Because the outcomes of, if we don't account, by accounting to these person-centered approach, the outcomes are benefit many outcomes, not only drug use. They have a common denominator. Why? Well, first of all, the services have to account for that it's not only a person-centered. A person-centered means it's developmental. So that person changes in different ages of development, right? And every age of development requires certain needs. But when we look at it into more details, more granulation, we understand that there are gender differences in development. On an individual basis, boys and girls develop at different speeds, right? So basically, just being at the same age does not mean that that age has the same level of risk, because boys and girls would at the same age would be at different level of maturity and requires different life and social skills to address their needs. Also, the environmental cues around boys and girls, the way they react to the environment are different. That's another perspective of individual approaches. And that's also an important thing, because if these are not accounted for during programming, this is where even an evidence-based program is, if offered to a classroom without accounting for the age of development or how the environmental cues can affect these people within that environment, that's an alternative way of saying this is a barrier for access to the essential prevention that you need, much like the equivalent that we see in treatment from a prevention perspective. But also the context is different. So basically, the exposure to risk and protective factors are different. So there's a difference in terms of amount of trauma and what kind of trauma the boys and girls and men and women are exposed to, the gender-based violence, the caregiver burden. And we say trauma, I mean, there's so many things that can be like put under a traumatic experience, the social stigma, right? And the norms that are associated between genders, the masculinity, the child custody risks, the legal fears, all of these translates in different ways between men and women and boys and girls. Peer influences and how peer affiliations are established, and what kind of peer norms exist, access to drug market and the kind of preference in terms of what kind of substances and drugs are marketed by gender, and kind of what normative aspects need to be tackled in that context are also key. So the exposure is different. It may be by risk or protective, but also the social consequences of the event itself and how it translates and how it mediates other things. For example, how trauma is translated, mental health, violence, all of these can mediate different aspects of substance use. And that's why it is very essential to kind of granulate our response and account for the fact that there are gender differences moving forward. Now, while we do not have all the knowledge with regards to gender sensitivity of evidence-based responses as described by the standards, we have some information that alludes to the fact that you see from the evidence that there are certain social contexts and social services where you see an equal effect between boys and girls when exposed to certain programs. Some of them are more positive than boys than to girls in the same age group for the same program. Some of them are more for girls than to boys. So basically, we know from the little available sciences, the science that exists, that yes, the same program will not have the same effect for boys and girls. However, also another way of seeing this is the fact that family and caregiving is one of the closest elements in terms of a gender-sensitive preventive response to account for. And this is why we have prioritized this in terms of our responses within UNODC and in the context of trauma. Trauma for us, in terms of, because we're working with children, adolescents, as you mentioned in the beginning, we have several aspects of trauma, but the main traumatic events that we're working with is from what we refer to as selective prevention, is working in low resource context, where there is high level of social inequalities, limited access to services or professionals, where there are particular needs, for example, high level of illiteracy or a high level of context in terms of like, the parental needs are pretty weak, armed conflict, complex emergency like COVID-19, disasters, hard access. So basically these environmental contexts would generate a population that's exposed to higher level of vulnerability and need other kind of protective factors to account for. So these are the main traumatic events. So we have separated trauma by itself requires a trauma-informed response. Gender requires gender-informed response. But of course, we have to get into the perspective of like a gender within a traumatic event is something that requires more generation. So I just wanted to give that context within the limited time that I have in the beginning in terms of why it is important. But from a practical perspective, especially from a caregiving perspective, I'm going to open the floor to my colleague Karen, who will take one specific example in terms of how translating this moving forward in the context of Ukraine. So hopefully with that, I'll pass the floor to Karen. I'm going to still control the slides, but Karen will take over the microphone. Over to you, Karen.
Thanks, Wadih. And thanks for setting the scene. What we do with the family skills prevention is we try to have a differentiated approach because of what Wadih mentioned, based on the specific needs of the individuals and the specific context, social contexts and interpersonal considerations that we need to take into account. So from the perspective of parenting and family skills, we've come up with this model that's based on a WHO pyramid of mental health services that looks specifically at interventions that are the most need and the lowest threshold. And as you go up the pyramid, the interventions that are more specialized and for more specific population groups. So I will explain. We've developed brief parenting advice and parenting skills leaflets and brochures that would really help at a very emergency, at a very quick level to get information to caregivers on how to manage and to handle their own stress and their own trauma that they are experiencing at that specific given moment. These are, like I said, low threshold and can just be accessed at a very quick and easy way. We've also developed a parenting seminar and booklets, which are more detailed and give more detailed parenting advice to caregivers. That if they want to know a little bit more information about managing their own stress and supporting their families in times of crisis or in times of high traumatic or high stressed environments, they can read up more about that. The program that we have been supporting the implementation of, I would say, with the highest level of research around UNODC's parenting skills programs is at the more detailed level as the interactive sessions that we have on called Strong Families program. And the idea behind Strong Families program is to really build the resilience of the caregivers and helping them learn the skills that they can actually practice, that they can implement and put in place in their daily lives, and that they can support their children to implement and for the children to practice and to learn those skills as well. And then for more intensive situations and for more intensive circumstances, we have partnered with War Child Foundation to implement a program that they developed called Teaching Recovery Techniques, particularly for children affected by war or conflict settings. And we've added to that a parenting skills component to assist them in addressing those specific needs in that context. And just to tie this back a little bit to what Wadih mentioned, we really understand that for parenting skills, the gender benefit for boys and girls, and for family skills programs, the gender benefit for boys and girls are equal and also beneficial. At the same time, these programs also work and have been developed and designed to work in conflict settings or in settings where trauma might be experienced by individuals and the family as a whole. If we can go to the next slide, Wadih. In the Ukraine, this is just an example to give you some of the work that we've done there. It's by no means the only country we work in. In fact, we have responses in Myanmar, we have responses that have reached Sudan, we have responses literally all over the world where there have been times of crisis and emergency. But in the Ukraine, we have specifically run a project with other UN agencies and with academia to distribute these parenting skills resources that, like the ones I've mentioned at the bottom of the pyramid, they are really low threshold and easily accessible to caregivers in times of emergency. The research on this will be published hopefully within this year, and it has the outcomes so far have shown some really positive results, even in just having caregivers read information about parenting and caregiving that could help them in times of crisis. We move on to the next slide. Okay, so our research that we are also at the moment getting ready for publication was some more in-depth research on the implementation of the skills-based course called Strong Families Program. We trained initially last year around 33 facilitators from frontline cities in the Ukraine. These are cities that are really more severely impacted by the ongoing conflict there. And through the intervention, we've also managed to gather information or data from around 84 caregivers across 7 regions, and they've gone through 3 rounds of the assessment, which is our data collection methodology timeframe. We go on, Wadih. The context of this is a range of factors, one of which is a report that was released by UNICEF. We had some insights pre the actual press release, but that's about 67% of parents in the Ukraine lacked access to essential parenting resources. And they also noted that around 86% of caregivers asked for dedicated national parenting programs, especially in the light of the war, and especially in light of the fact that a lot of the families were having experienced one caregiver that was absent due to having been fighting or being part of the conflict. So we did some baseline interviews, and these are some of the quotes that we got from the caregivers, most of whom were mothers. We live in Kharkiv and we're under constant bombardment. It's been a very stressful time for our family. So any opportunity to receive support and strengthen our parenting and meant that she was happy to join. Another mother mentioned that when rockets are flying overhead, which they do very often, that she panics and she knows that her child is also scared, but she doesn't know how to calm her child. And then after the first session, they felt a lot calmer, and the exercises that they were introduced to really helped. It's also within our global mandate. WHO guidelines on parenting interventions to prevent maltreatment and enhance parent-child relationships also call for evidence-based parenting skills in humanitarian settings, noting so importantly that parents and parenting skills are a foundation of safe and healthy development of children and youth. And that Strong Families is, of course, its direct application in the Ukraine. Wadih? Thank you. So these are some of the preliminary findings. We have not yet finished the findings enough to be at the stage of publication, but we're getting them ready. We're almost there. At the initial assessment, at initial observations, we can see that there have been sustained improvements in child behavioral difficulties over time. The SDQ assessments showed that there was a reduction, particularly amongst the top percentile, which was around 25% of the participants. They had the highest difficulties that was started at about 26.6 of the SDQ scores, and it fell to about 21%, which is, again, it's still very high, but it's also important to know that in a short frame intervention, this has been a real significant reduction or improvement in improvement in child behavioral difficulties. That's the right word, particularly amongst the most vulnerable children. If we can go to the next slide, I want to make sure I can keep time. Then we have another sort of metric that we use for measuring whether the program has some positive outcomes. It's called the PAFAS, Parent and Family Adjustment Scales. And this has shown that parents have become less stressed and that it lasted over the 3 time points that we have been using to collect data. There's about a 27% reduction in parental stress at follow-up, according to the data that we've noted so far. We move on, Wadih.
1 more minute.
Yes, okay. So just to say that we continue to work in Ukraine, we have an ongoing project there. We have trained already an additional 40 facilitators in the key regions, and we aim to reach another 300 children, noting that still more needs to be done because of course, it's an entire country that is in conflict, and these numbers are within the grand scope of things still quite small. So having support and working with local partners is a very key priority for us. If we can move forward. And some of the good thing I'd like to end on is just some of the quotes from the caregivers at the end of the program, talking about, for example, one mother in Dinpro mentioned that they would never have discovered this at their home on their own. So they were really happy that they attended the program and that the child now understands her. Another mother mentioned that the child started letting them know wherever the child was, and that she understood that the mom was not trying to control her. She just wanted to know that it was safe. And another mom mentioned that instead of ordering her child around, she tried a different approach. And then after some time, the child would text her and said, "Mom, I've done it." And then they had some time still left to do something fun together as a family. So we really have seen actual great results out of these evaluations of this program. We have still some, for the trauma teaching recovery techniques, we've also done some evaluation, including with the parenting skills component. And this is just to say that this can be found on our website. You can get a link to that as well, some of the research that's there. That this is also an area where it's not being left behind. We're also making sure that children that have really experienced PTSD and trauma can also be helped. And you can find more information by scanning that QR code to access UNODC's website.
Thank you, Karen, both Karen and Wadih, for your great presentation and again highlighting the importance of gender and trauma-sensitive prevention and treatment, not only separate aspects of gender responsive or trauma responsive, but that they both need to be together, and also share your incredible program, the Family and Parenting Skills Program. And it's good to see that that there's such good feedback already. As you said, there's still much more to be done, but it's a good indicative that it works. So thank you so much. I would like to open the floor to questions from the audience. And in the meantime, I would also like to share a little Slido, let's say, for the audience to kind of also share their perspectives. So a little bit of interaction. So here you can see a Slido QR code, or you can join via the website, slido.com, and then type this code. So I'll give you a little bit of time, maybe a few seconds to scan it and go in, and then we'll ask a question, which is, we'll be asking you on how you have what kind of needs you see in prevention, and hopefully we can kind of open up a discussion in that. So I'll just... So for example, here you can still scan the code if you're not in yet, but the first question based on this presentation is which area would most strengthen prevention efforts in your community right now? When we were talking about trauma or gender, we know that not every area in the world has currently maybe conflicts as such, but trauma is always important, whether there's a conflict or not. But maybe what do you see most important in your community right now? You can select several answers. Seems that the topic of today is very timely. Trauma-informed approaches is very much on the top, it seems. So hopefully the tools that were given today and the information that was given today is very much is supportive in that. Youth engagement as a second is also very interesting and very important too. And actually our next session next week will be all about youth engagement. So we will definitely recommend you to focus on or like join us during that session. In case you would like to ask a question, you can also unmute yourself or raise your hand to ask a question. All right, I'll stop sharing for now. Sorry, my laptop is getting a little bit slow with all the different things on the side. But in that sense, I would like to pose a question to both you and Wadih based on the presentation that you gave today. I know we talk a lot about theory, and you already showed a practical example of the Family First program. But what is another practical prevention approach that smaller NGOs, maybe also in lower resources, can begin using immediately to improve their programs and being more effective also when it comes to youth engagement and trauma-sensitive approaches, which we have seen now in the poll?
If I can kickstart the process, it's two-level. It's the advocacy of the science of prevention per se, and the person-centered approach that is described in the standards is there, right? And then there's a lot of already webinars that kind of describe it, but most of the people around engaged in this understand this, and kind of putting the community around the common agenda, understanding what prevention is, and not any investment in prevention is prevention, is one of the ingredients that kind of helps those that are investing understand where it's going, and breaking the silos between the different approaches. That will be a practical thing to engage with. When it comes to actual prevention, the reason why we're working on caregiving is we said like we know it works for both from a gender perspective. It's not enough. We need more research that comes in from other perspectives. But maybe Karen would have more to add, not to take all the time to this question.
No, I think that's a very apt question, Cressida, because I mean, the point that Wadih was making in the beginning just comes to mind. Like, we like to think of prevention as only one thing. But actually, when we look at what the root causes of a lot of the struggles that people are dealing with, whether it's drug use disorders or problematic drug use or violence or crime, they all have a common foundation, and that is to ensure that there is a healthy and safe development of children and youth. So again, we can of course refer to the standards if we want to look for an intervention to apply. But if that is not within people's reach, then look at what is available that's going to make sure the children, the young people are in a safe and caregiving focused setting. The other thing when it comes to trauma, we always think of big things causing trauma. But there's a lot of things in our daily lives now that are really impacting us. You know, when COVID-19 came into the picture, it kind of crept up and we didn't really know how to deal with it. And that's how the program was just adapted to address the challenges of parents that are now living in the house with their children that can't go to school. You know, this is a traumatic, it's not traumatic to have to take care of their kids, but it's traumatic to have this big change in your life. Who of us are not experiencing big changes, whether on a geopolitical space or on interpersonal space right now? You know, the world is in a different time. So yeah, it's always interesting to look and see where we can really support efforts that are really helping people be whole, holistic, whole, mentally, emotionally, socially.
Thank you, Karen and Wadih. That is a very good and important answer. I have one more question before we move on to the next speakers from Ella Constantine in the chat. She's asking, have you explored integrating earlier childhood interventions, ages 4 to 8, that builds emotional regulation and decision-making before behavioral challenges emerge alongside your current family-focused programs?
Indeed. I mean, explore integrating is a big term for us because in terms of the prevention standards advocate for and showcase that evidence-based prevention starts not only between 4 to 8, you know, as early as when the child is in the embryonic stages and the pregnant mother. This is how early we can intervene. And the other thing that is very important is the fact that the first 3 years of life in terms of development are key. So I cannot but really echo L. Constantine. So it's not a matter of exploration. The evidence is there, and the earlier you intervene, the better. Unfortunately, most of the intervention, depending on what area of intervention or prevention you're working on, for example, on drug use, occur in the age when the problem happens, you know, and this is where we have most research. But the earlier you intervene, the better. And family is an important social institution because it is one of those social institutions, if it acquires the skills and adapt the skills over the years, can have a long-lasting effect, unlike school-based intervention where the teacher only intervene within a specific age window. So I cannot but echo the message that was mentioned and not mentioned that we have explored it, but we've been advocating heavily on. And there is an attitude of moving to earlier ages of prevention now with policymakers.
Thank you, Wadih. Yeah, so thank you both, Wadih and Karen, for your wonderful input for today's presentation and for your time. It's been very valuable to not only myself, and I believe also to our participants. And with that, I would like to also move to our next speakers, which are Susan Maua and Caroline Kahiu, who will share insights on effective prevention models on gender-responsive approaches. We stay on topic. So Susan Maua is the Deputy Director for Capacity Development at NACADA and oversees prevention training and programming across schools, workplaces, families, media, and communities. And Caroline Kahiu is a Senior Country Coordinator at NACADA and a strong advocate for evidence-based prevention in Kenya and across regions. Susan and Caroline, the floor is yours.
Thank you, Cressida. Thank you, WFAD, for this opportunity to actually begin to have this conversation. And also, thank you, UNODC team, for actually starting us off, because you see, they lay the foundation and we pick up from there. And that is essentially what we've been doing. Even the international standards we've domesticated so that, you know, we begin to respond in a way that actually makes sense. So we are going to now present on what is it that happens even in a low resource setting like Kenya. And so what do we know? We are going to look at it in two ways. And one, Caroline, you can move the slide. What do we know? And then we will also talk about what needs to be done. So I will cover what we know, especially in our own context, and then Caroline will cover what needs to be done. So we start with what we know. And one of the things that we can talk about is in the drug use prevention, we know that particularly given that it's an evidence-based approach, it is children and youth, because this is where it all begins. We aim towards if they can avoid, that would be the best. Abstinence is the best. If we can delay the initiation of drugs, and if they have started using, how do we prevent them from developing substance use disorders? And from these continuum of services, you can see that prevention basically looks at those three areas: the universal, selective, and indicated. So if you are talking about gender sensitive, then and even trauma, then it means we are already focusing on the selective group. So next slide. The other thing that we also need to appreciate, and we know in our own context, that trauma takes many forms: child abuse and neglect. And when we look at neglect, we are talking about the physical neglect. We are talking about emotional neglect. And there is data to that effect. It's only that now, in our context, you find that they are addressed by different sectors of government and even non-governmental organizations. So that means that even before they merge all these together and talk about it. Then we have medical neglect. We actually have situations where people think, oh no, we don't need to take my child to hospital, just need to pray for them. There is also the educational neglect. That somebody thinks, no, this child does not need to go to school because, and more often than not, it is looking at it from a religious point of view. Then, of course, there is also the sexual neglect. Now, all this, we now also have data on domestic violence. So it's not just the female, although many times when we talk of gender, people think female, and therefore that means that males are actually left behind with that. So domestic violence also cuts both ways. And then one thing that we found out, and even from my own study, bullying and discrimination is actually something that you may have thought should have gone down by now, but it's actually. The other thing that we know is that trauma can be transgenerational, so that even in the event that I come from a family where there is domestic violence, even if I were to go back to my parents and say, you know, that is normal, that is how men are, and so on. So it means that, you know, it gets passed on from one generation to another, and they don't seem to realize that it's actually a big issue. Next, the other thing that we also can compare is the vulnerability status. Because like I've mentioned, many times when we think gender, we think female. But more and more, it's actually coming out in our own context. Like if you look at the males, you expect to see higher rates of alcohol and drug abuse, emotional suppression, because you need to be manly. You know, you don't show your emotions, that is girlish. And then the risk-taking groups, we also like to say, oh yeah, you know, boys are like that, and therefore a lot of what they experience actually gets ignored. And that is where there's also a very strong pressure to appear strong. So you need to man up, man up, man up. Now, on the female side, there are higher exposure to sexual and gender-based violence, and of course that comes with stigma and discrimination, and so if you add even the transgenerational aspect of it, there is minimal access to interventions. So it is only when such cases are reported that you find people respond to, but more often than not, very little is done about it. Next is outline the next. So what do we see also in child maltreatment? Because more of it is stemming from even caregivers. So perpetrated by caregivers, as even the first speakers put out, women are likely to be physical abusers and also neglect. And that it's mainly because they spend more time with their children. Men, on the other side, sexual abuse, and when they are involved in abuse, it actually tends to be very severe or fatal. And now, we also know that substance use is often a coping mechanism. Actually, more and more, if you have one-on-one conversations with children that are experiencing this, you will always find that as they are using drugs, they are actually trying to cope with some underlying issue, whether it is stress, it is anger, it is violence, it is all these forms of maltreatment. And we are also aware that gender-specific prevention is actually rarely applied, except now when there is, like teenage pregnancy, as we also saw escalated aspects of teenage pregnancy during the COVID confinement period. So that actually tells us there is a lot more that we actually need to think about. And so it is quite critical, because then what we see is in their growth, what happens is poor emotional regulation. And therefore, the way they are even going to express themselves tells you that there is actually a missing link. They are likely to be less empathy. And we are seeing more and more of this, even when you look at the youth population. There is less empathy that we see, fewer social skills, poor academic performance, so that even in the event that somebody needs to move on to the next stage, they feel, I don't need to go so far. After all, many people have done well even without, achieving this much in education. I can do well even without academic achievement. And then, of course, there is less motivation, more and more. So the kind of things that you find the young people like to engage with, sometimes we do not seem to see that there is this underlying issue, particularly when it comes to men. Of course, there's been a lot of conversations about the boy child being neglected and so on. So that is an issue. And therefore, what is expressed or what people get to see are the behavioral problems that actually present in the young people. So in a nutshell, that is what I can say we see in our context. And I would like to hand over to Caroline to actually tell us what else, what is it that can be done.
Okay, thank you very much, Susan. Thank you, Karen, and thank you, Wadih, and also to WFAD for setting this space. So the biggest question that we're asking ourselves is what needs to be done. So let's see what we can do. So one, we need to have inclusive and targeted prevention that will be able to look at issues of prevention and also gender in the same lens. So where do we start? The first thing that we need to do is to begin the conversation. And I'd like to thank WFAD for this opportunity, because right now we are starting to have the conversation where we don't separate gender issues and prevention issues, but you're able to talk about both in the same time frame and also in the same scope. The second thing is that we all know about, when it comes to prevention, there is the universal, which Susan spoke about, the selected and the indicated prevention interventions. When you look at the universal, we talk about almost like a one-size-fits-all, but to be able to bring in the aspect of gender and also in the prevention conversation, we need now to move to the selective intervention, whereby you can have a conversation about prevention that is focusing on women, prevention that is focusing on children, and also prevention that is focusing on the men. Then this is borrowed from the treatment aspect, whereby you can see we have curriculums that deal with women, that is the WISE curriculum, and then we have child that deals with the children who are already using drugs. The other thing is that we need to tailor our protective factors. Wadih mentioned this in their presentation. When you look at our society, the girl is usually at home with the mother, with the sisters. So we need to make the home environment safe for the girl so that we can be able to deal with the issues of trauma. And I like the fact that someone mentioned that the earlier, the better that we're able to deal with this. When you look at the boys, you'll always find them out playing. So we need to make sure that the environment is safe for the boy child to be able to enjoy their space, but also they are safe from issues of trauma and also issues of substance abuse. The other thing that we can consider is to integrate screening tools in our interventions for prevention, which will be non-invasive because of issues of consent. So you should be able to, when you're doing our routine checks, when you're having those conversations with boys and girls and the men and women, we need to ask, are there traumatic issues that this person might have experienced? So that's even when you're doing a prevention intervention, it is able to take care of issues of trauma and drug use. So the other thing is that Susan has alluded about stigma, and also the issue of trauma has cut across the whole presentation. So the first thing that we need to do is to build capacity for people to be able to understand what is this stigma we are talking about, what is this trauma we are talking about, and how do we go about in terms of empathy-driven responses. So the more we talk about it, because we said we need to have the conversation, then we build the capacity, then we start to normalize it. The next thing that we need to do is to have a paradigm shift, whereby we'll stop asking what is wrong with you, and we start asking what happened to you. When I ask you what is wrong with you, I'm already speaking about you. But when I ask about what happened to you, I'll be able to know the issue. So I will no longer be stigmatizing you or assigning maybe trauma and substance use to you, but we will be dealing with the issue that you are going through, and then we will be reducing the issues of stigma and discrimination. When it comes to trauma, we know we do trauma-informed prevention or trauma-informed care. So when we talk about responsive, we need to move away from the conversations about trauma information to trauma responsive. And this we can do that by adapting lived experiences and fostering issues of resilience. The lived experiences come in place because that person can be able to relate with. So that, but you don't use the lived experiences where people have not undergone the traumatic events. We use it where people already have that traumatic event so that they can be able to relate with. Then the other issue we need to look at, this is the last one, is that we need to look at the structural and environmental transformation. So how do we go about that? The first thing we need to do, one, is to remove the barriers. The structural barriers, how we go about it by localizing our interventions. I like the example they have given in Ukraine, so that we look at the country and we move away from the country, we come all the way to the community level, so that because that community has their specific needs, so that you can be able to look at that intervention at that level. The other thing is what you're calling genderizing services, that even if I walk into a facility, will I be able to find someone that I can be comfortable talking to, especially on issues of gender-based violence or sexual-based violence, so that I'm able to share my issues, and someone maybe who is of the same gender with me is able to respond appropriately. The other thing is that, of course, our spaces need to be safe, both physically and the digital space. The physical space, that, like I have alluded, is that when you remove the barriers, of course, you can be able to make the physical space to be safe. When you look at the digital space, where we are at the moment, for example, when you go to a chat box on our website, mostly maybe if you'll find maybe the, hi, my name is Mary, hi, my name is Carol, but assume I am a man, I find, hi, my name is Carol, and I want to talk to a man maybe because I've undergone some traumatic event, which can include even sexual and gender-based violence. But as I was thinking about it, I thought, could we be able to ensure that even our chat boxes, we're able to choose that if I'm a man, I can find a John. So if I go and I'm John and I say, hi, my name is John, I'll be happy because I'll see this is maybe someone who will be able to understand what I'm going through. Then, of course, the peer-led advocacy speaks also to ensuring that we have, we use the relatable voices, which are mentioned that needs to be present both in the physical and in the digital space. Then finally, we cannot do all this without looking at our research, our policy, and our institutional integration. Of course, we do our research, but I need to move a step further and ensure that the data that you are collecting can be able to help us to also ensure that the policies and the programs that will be developing will be able to help us to intervene appropriately. I've mentioned that the policies that we do, which will be grounded on the research, the data that we get, it will be able to help us to deal with the issues that are gender responsive and also trauma responsive. Then finally, our institutionalization. We need to normalize the issues of prevention in our conversations. That even when you take into consideration the frameworks across our institution, I have seen, like in the treatment field, this has really worked. But when it comes to prevention, I believe there's a lot that needs to be done to ensure that our prevention, our institutions are able to respond not only to treatment, but also to issues of prevention, and also bring in the aspect of gender and the trauma. And then when you look at this is in a nutshell what needs to be done. If you are to have that conversation about gender and prevention on the same page, this is what I've spoken about, and this is how it would look like. So in conclusion, our key takeaways is that one, we need to stop making assumptions, because when we listen to our children, when we listen to the boys and the girls, then we'll be able to know what is going on if they have undergone through a traumatic event, and what intervention can we put in place. So we need, as they say, we need to listen more and not to judge. Then number two, we need to ensure that effective prevention tackles the issues of trauma, violence, stigma, and harmful social norms. Karen alluded to this. We are not going to be able to address prevention without looking at traumatic event, because even that child who might be 2 years old, 5 years old, 10 years old might have undergone a traumatic event. So we need to take cognizance and recognize how are we going to deal with this traumatic event, the violence that might be there, the stigma, and also any other harmful social norms that can include, like maybe in our context, issues to do with female genital mutilation. Then finally, we need to know where and when to refer. We need to have that data on where can we refer, and we refer appropriately. We do not refer so that they can be referred again. And then also we need to know, where does our job end? If it ends at the screening, then we need to know, where do we move, or where do we refer this person, and to ensure that the intervention will also be gender sensitive, and it will be able to take care of issues of trauma. So finally, Susan told us that trauma can be intergenerational. So if it can be inherited from one generation to the other, so can the issues of love, emotional intelligence, and wisdom. Thank you very much.
Thank you so much, Caroline, and also Susan, for your wonderful presentation, and also a very important presentation, which really adds to what indeed Wadih and Karen have said already, highlighting the need for trauma and gender, but also how to do it. I think that is indeed a very important discussion, and have that constantly going on, and change the discourse, because oftentimes we don't have these kind of conversations, but to be inclusive, and also to, what you said in the end, I think was very powerful, to stop making assumptions in any level of treatment even, or prevention, but even on family level, etc. I think that we need to listen, and make sure that we provide the necessary support. So thank you for that. So with that, I also again want to go back to the Slido that I shared earlier, while I also provide time for our participants to share questions in the chat or in the Q&A, to share your questions to Caroline and Susan. So let me go to the next question. What is the biggest priority for improving prevention or support services for women in your context? So thinking about the field in the area that you're working in, what is lacking at the moment, and what should be the biggest priority in your case, is the question. For those that joined a bit later, you can join us by scanning the QR code in the top, or go to slido.com and add the code that is mentioned as the hashtag. Just leave a few moments. seems like most of it is quite important, but trauma-informed support, again, is kind of on the top of the list. It really shows that it is an important aspect in our discussion as we are moving forward, but also childcare and family support, reducing stigma, and also mental health services. And I think here you both, Susan and Caroline, you already mentioned of reducing stigma. It's all about the discourse and how we frame certain discussions, how we ask certain questions to the children, not like putting any trauma on them or putting any substance use on them, but more asking like what has happened so that they feel a safe space to open up. So I think that really reflects in that discussion. Would you like to add any other observations, Caroline or Susan, based on the output that you see here when it comes to the points given, especially when it comes to childcare, family support, and maybe mental health services?
Oh yes, and you know when we thank you for even bringing this up, because there is actually, as just like I mentioned, that substance use in itself is a coping strategy for underlying issues, and from our own experiences, it's coming out the mental health issues, and because we also talk about co-occurring disorders, and sometimes people don't want the aspect of even mental illness, because it is better to probably suffer from a substance use disorder rather than a mental illness. So you can imagine if it is combined, because the issue of stigma and coming from the cultural context, actually you're likely to be interpreted to be bewitched rather than sick. So you see, those are things that then we need to understand. And therefore, trauma, like we said, is something that has really not come to the fore. And I also mentioned that there is a tendency to address things in compartments. So it is only when those who deal with gender-based violence find that substance use is becoming an issue, then they contact NACADA, for example, because then they realize that they need to bring this on board. So we've been incorporated even in committees that in the beginning, they probably did not see substance use as an issue, but then now they realize it's something that keeps coming up and therefore must be addressed. And therefore, it's very important that all these three aspects that I'm talking, mental health services, the child care support, and particularly even for families, because when families are stressed, then definitely it is going to be the children who suffer the process. And that is why the emotional, medical, educational, physical neglect is going to come in, because they cannot cope with this. And therefore, if we can actually incorporate trauma-informed support, then it's going to make a huge difference for children and youth. And in this case, I'm also bringing out the fact that yes, a lot of focus is on women, and yes, women suffer more, but more and more we are also seeing the boy child or the male is getting neglected, but they are also experiencing the same. And probably that is why they also react by being violent and so on. Thank you.
Yes, thank you. Just to add on to Susan, I like the fact that the issue of trauma is coming out clearly, especially in conversations to do with prevention. Initially, we would see trauma-informed, trauma-responsive, edging into the issues of substance use. But now when you talk about it right now, prevention, yeah, Susan reminded us that our role is to delay initiation, to avoid initiation, so that the group that is already using substances, they are not going to cross over that they will need treatment, that by the time they're getting into treatment, that is the time that you're going to start looking at, did you undergo any traumatic event when you are young? So that I like the fact that we will be able now to continue having conversation about trauma in prevention conversation. And then also the family support, that goes without saying. That if the family is safe, and we have seen the programs that the UNODC is implementing, then we will not be having all issues. They will not come up. And then Maybe the other thing that we need to think about as we move along is also having male or men safe spaces, whereby even the man that Susan is mentioning, they also need to have those conversations. Because like exactly where I work currently, we have a lot of high cases of suicide amongst the men. And when you find out and you interact with the ones whose suicide cases were not successful, you'll find out it was the issues of trauma, the issues of family, the issues of unemployment. So if we also create that for the men, then it is going to be of great achievement in prevention. Thank you.
Thank you both for very important additions. I think it, like you said, Susan, when it comes to gender, we often think about the women, but it is indeed, it continues to be an important topic, but it is so important to also include the men and the boy child in the discussion, as you also say, said Caroline, for like, yeah, it is often a big circle. You know, it starts somewhere young, and then maybe some behaviors being learned and not listened to, and then so on, and then it is going to be then also then again being portrayed later on in life, and maybe to another, you know, person in their close family, and it becomes intergenerational or transgenerational. So yeah, it's very important to have this discussion of trauma when we talk about prevention, I think, because we do want to delay the initiation and prefer to avoid it even, and with that we need to make sure that are safe environments. So thank you both, Caroline and Susan, for your wonderful presentations, for giving such great insights into the topic. It's been very useful and educative, so thank you so much. With that, I would like to introduce our final speaker, Monica Barzanti. It's an honor. She will speak also about the gender dynamics and the importance of trauma awareness, but also the support for children whose parents use drugs. She is the head of international relations at San Patrignano and brings decades of experience in recovery, prevention, and international drug policy. Monica, the floor is yours, and I'll share your presentation on your behalf. Just 1 second.
Thank you, Cressida, and thank you everyone here. And today my presentation will focus and is focused on the on what we learned into 48 years of working in the area of recovery and social integration, but also in the area of prevention. So it is something that is a mix between what research and studies say and what we have done and still continue doing in these years. We learn actually from our residents as well as we continue learning from the students we meet every day in our prevention project. So next, please. Well, there are many findings regarding gender and drug issue that should inform drug policy. In recovery, many things regarding gender are being implemented now, but not that much in the area of prevention. While it is very important to understand that girls and boys are very different and require a different approach. We know that girls and women have specific drug use partner. Girls start using drugs mostly with a male partner, which means that we should work in the area of effectiveness and emotional and relations in order to strengthen girls to be resilient in front of this situation. We know that women are more likely to have underlying issue, early trauma, ACEs, so it is important an early detection of this situation, especially in girls, but not only, also in boys. They also are exposed to further abuse during the period in which they start using drugs. So this is another important element. Women and girls also progress more rapidly than men into severe dependency and develop medical, behavioral, social, and mental issue in a shorter period. So this means that an early detection is crucial. However, women, because of stigma, because of internalized stigma, tends to leave the dependency in a hidden way. So this makes the early detection more difficult very often. They are at high risk of infectious disease, and this is particularly true for girls and young women, not only because of the use of drugs, but also because of unprotected intercourse that they might have. And the rate of girls using drugs is 1 out of 3 men. However, we assist to a narrowing of the gender gap into the younger generation. Another important thing that we have seen in our resident is that drug use disorder is intergenerational. Might be, but is quite often intergenerational. Next, please. For this reason, it is important to address parental substance use. This is the first line of intervention, the first line of prevention. If we help families to improve the quality of their life, their approach to children, their family life becomes a better environment in which children can grow healthy. We, of course, can change the life of these children and break the cycle of addiction. I participated into an important study made by the Pompidou Group. The title is Children Whose Parents Use Drugs. So you can find more publication at the link you can see there. And it is quite crucial and evident that parents' drug use was one of the most important risk factor for children to develop substance use disorder, and not only. Because in families where there are dependencies, there is a tendency to accumulate more ACEs. So not only parents with substance use disorder, but neglect, but emotional distress, marginalization, and separation from an healthy growth with other children, poor school performances. So the adverse childhood experience accumulate and tend to give the result that children become substance use addicted as their parents. So next, please. So at San Patrignano, we try to offer this family an environment in which they can have safe housing for women and children, psychological support, help them to regain confidence in their parenting abilities, trained staff that know trauma-informed and family issues so that they can offer support, real support, peer support, which is crucial, and offer families formal education in order to be able to overcome also the economical and social issue that might prevent them from a good integration back into society. Next, please. But how this idea can be applied into prevention. We created this prevention project more than 25 years ago, and we reach out students from 11 to 19 years old. This is a very, we of course implement a universal prevention, but the group we reach out is a very high risk group, because in this age, adolescents are more vulnerable because their brain is still developing, because their peer pressure is, they suffer more peer pressure, because they can use substance use for coping with mental issue or adverse childhood experience or trauma they are experiencing within the family or in the peer groups. And also because at this age it's quite easy to access substances. Many friends use them. It is quite easy to find the most common drugs, substances, including alcohol, cannabis, and other kinds of substances that are quite easy to obtain. Next, please. I try to understand and separate, let's say, understand better how girls and boys react differently, in a different way, this is something that we should know and learn in order to be aware of the differences between girls and boys. For example, they might develop mental health because of ACEs or because of neurobiological issues. However, while girls have internalizing disorders such as anxiety, depression, eating disorder, or self-harm, boys, on the other hand, have externalizing problems. They have anger, they get aggressive, and they have a larger number of diagnoses for ADHD. On the other hand, eating disorder, which is always considered a typically female problem, on the contrary, is present and increasingly present also in boys. Of course, identity crisis is something that is part of the developmental challenges of adolescents. However, the girls might face it with a higher rates of anxiety and depression and social emotional pressure, while boys tend to adopt the traditional assigned role for of masculinity, which is required by social roles, social norms. So this makes them in appearance more at ease with their identity. However, they might develop problems later in young adult age. Another problem is the smartphone-related social use disorder, which is present in boys and girls. However, girls suffer more social anxiety and use a smartphone for social media texting, while boys tend to use it for gaming and for gambling. Recently, we have had a huge increase in gambling in young adolescents and young adults. Regarding anger, aggression, and bullying that might be experienced or perpetrated, girls are often taught to suppress anger, and so they engage in different relational aggression. They are not physical like boys are. Another important impact that social media had on girls and boys is the self-esteem and body image. That while on girls result into a lower self-esteem and image satisfaction, boys tend to increase and exhibit a muscularity and masculinity to show how male they are. A problem which is increasingly present in the students we meet is gender dysphoria. Both groups present severe distress. I would say that the percentage of people who suffer from gender dysphoria that turn out in using drugs and substances is very high compared to other group of adolescents, because this is a very distressing situation. And the number of girls that is increasingly showing and presenting gender dysphoria is increasing very rapidly. Now it is the higher number of people presenting in gender dysphoria of girls between 15 and 19 years old. While male that tends to hide this situation until young adultness, they show psychiatric comorbidities later in life. The situation which adolescents address in order to heal all these challenging and difficult situation is use of alcohol and drugs. In this area, girls tend to override their peer male in binge drinking, use of prescribed medication, and while on the other hand, the boys have higher rates of drug use, generally speaking. Next one, please. However, it is important to know that the use of drug is not a status, but it's always a trajectory that can be interrupted at any stages, because adolescents start experimenting with drug use. They're driven by curiosity, fun, desire to try something new, but also to the search of something that can somehow change their emotional distress. Then when they discover that this substance use can really gives them a sort of healing to some of their distress, the substance use become cushion with they are aware that they use drugs as a coping mechanism for the developmental challenges and also emotional difficulties. Then they start with habitual use, regular use, consumption, increase the tolerance of drug use, so they increase the amount and also the different kind of drugs, because today's adolescents use a wider number of drugs, not only concentrate on one kind of drug, they are polysubstance user. And then later they develop substance use disorder. So we can intervene in each of these phases and try to support children and avoid to progress into severe substance use. So this is the age in which we work. The student, next one please, the student we work with, among them, there are 25% of them that has been tried one kind of drugs at least once. So it is important to work with this age group in order to prevent that experimental drug use develop further into dependency. We know that reducing X factor is crucial, helping children to see new and different perspectives in their life. I mean, help them to understand which is not inevitable to use drugs, that it is not the only way to have fun with other adolescents. And it is important to help them to understand that there are other ways to enjoy life and to have a situation in which they can stay together and avoid using drugs, but enjoy life in a different way. Next one, please. At San Patrignano, we created this prevention project. With the prevention project, we try to help the students we meet, 60,000 per year, that their action have consequences on themselves, as consequence on other people, friends, peers, on their family, and on the entire society. So the idea is to encourage them to take active roles in positive change. The word that we should depend on us is the claim of this project, because we help adolescents to understand that the world they want is not something that they can't change at all. It is a world that they can do something for creating a positive change. So in this way, they feel empowered. They don't feel any longer helpless and hopeless, but they understand that they have the power to do something. Starting from small, they can, however, create a different environment around them. In this way, we create a safe environment in which they can feel safe to tell the issue and understand that many other adolescents share similar issue. We know that adolescents always feel that they are experiencing something that no one else has never experienced in his life or her life. However, when we create this safe environment in which they can talk each other and share stories, they see that there are similar situations. Other children, other adolescents live similar anxiety or anguish, and so they can repositionate their issue and feeling the power to do something positive around that problem. We encourage especially the dialogue between gender, which is one of the main challenges adolescents often face. Next one, please. The project, the main project that we offer to the students we meet is tutor of prevention. We create situation in which a group of students is strongly trained and empowered to become tutor for prevention in their school. We train them. The project is developed over many different interventions, school training, community experience. They come and visit San Patrignano, stay for us with a couple of days. They participate into workshop in presence and online, and we encourage peer communication. The final outcome of the program is that they organize prevention activities with their schoolmates in their school. Next one, please.
1 more minute.
Yeah, I've finished. So how the project is based? We use personal storytelling. I know that people with lived experience are seen with suspect when they are part of prevention project. But we think that as they have become crucial nowadays for favoring recovery process and social integration process, we think that correctly used, the storytelling of people with lived experience in the area of substance use disorder can be fruitful. We use authentic experience, but elaborated in a way in which a youngster can identify and understand that you can react differently to the challenges that you might meet in your life. We do not talk about drugs. We talk about emotion and how to face them. So this creates a strengthening protective factors that help children to understand that there might be different ways to face the challenges that they have. They create a safe environment without judgment, in which people can listen and talk about their vulnerability without feeling judged, because they all share the same situation. This can transform students into leaders in their group and positive leaders. Next one, please. Okay, I've finished. Thank you for your listening to what is a concrete experience. Actually, it's not based on study research, but we see every day the changes that can be created into adolescents when they are listened to. They are eager of someone that listens to them, that tells them real situation, that can consider them as protagonists of their own life. They need to be listened to, and listen first actually is one of the claims that you also shared, the previous speaker shared before.
Thank you, Monica. That's indeed a great, I think, closing presentation of today's session. And I would like to thank you for highlighting all the different great prevention programs that you're doing, but also at the beginning that you shared with the gender differences, and that this should be considered in all aspects from prevention to recovery. And I really enjoyed the framework that you put out there, the matrix, in a way to really clearly showcase the differences. Even though there are similarities, there's also still very much differences, and they need to all be integrated in our responses. So thank you for that. I was going to have a question, but I think we're close to the ending time, so I don't want to, take too much time of anyone. But if anyone has a question, please post them in the chat, and we can just maybe add one more question. One question in the chat is actually that, are you able to do the TOP training online? Is it free? from Thomas.
Well, we know that prevention projects are not funded very much in many countries. I mean, funds are often given to other options, but prevention are one of the less funded activities regarding drug use. We have fundings from the National Health System, from Department Anti-Drug Italian policy, anti-drug policy, and we also have collaboration with companies that offer this opportunity to their local citizens. So we offer this project for free to the school because our costs are covered by these fundings, actually. So especially the online projects are the less expensive one, and they are easily covered by also by not important fundings, let's say.
Thank you, Monica, for that answer. With that, I would like to not only thank you, Monica, for this wonderful presentation and great insights. Anyone else who has more questions, you can always reach out to us, and also to Monica. She shared her email address in the slides. I want to thank all our speakers here today for sharing their expertise and practical insights, but also thank you to all that joined for actively contributing to the different Slido questions and also in the discussion questions. And I hope today's session was very much of a useful session with lots of reflections that you can bring back to your own community. And this is only the beginning of the series. As I said, we are looking forward to welcome you to our next session, which is next Wednesday on May 6th at the same time as today, where we'll be joined by the incredible youth panel and focus on the essence of youth engagement and participation. So thank you so much again, Wadih, Karen, Caroline, Susan, Monica, for joining us today and sharing your insights. And thank you so much for all the participants. We hope to see you again next week.
Thank you, Cressida, for all of you, for organizing such interesting, all the speakers